My name is Shanda Corral, and I'm a clinical psychologist here in Kansas City. And I specialize in obsessive-compulsive disorder treatment. That's sort of the route that I kind of landed in the perinatal world, because once I started studying that more in depth, then I realized that this is a major concern within the perinatal field, and it's just often misunderstood, misdiagnosed. We're really working on raising awareness about this for that reason. Before I get started, I'm curious about the audience here. How many of you are clinicians or clinicians in training? And then how many of you are from the community? Just an interest in it? Okay, so what I wanted to do first is go over the disorder of obsessive-compulsive disorder to really understand how this plays out in the perinatal period. It's just important for me to go over the symptoms and the common misconceptions about OCD. There are some true things that you hear about in the public, but there's much more to this condition than the general public usually is aware of. So I'm going to go over just the basics of the disorder, a little bit on assessment. That's kind of what I'm hoping will happen in medical and psychiatric and mental health settings, not that it necessarily does. The peri and postpartum OCD symptoms, and then a little bit on treatment. So what do you guys think of when you first hear obsessive-compulsive disorder? What comes to mind?
Obsessing over things.
Obsessing over things.
Doing things over and over and over.
Doing things over and over.
Like germ cleanliness, nervousness.
Germ cleanliness, and what was the other?
Nervousness about germs.
Nervousness about germs, yes. Okay, so those are all correct things. The big point that I want to make with the diagnostic criteria is to differentiate an obsession from a compulsion. It helps you understand the condition better. So an obsession, clinically, we look at this like as a noun, not a verb. So instead of I'm obsessing over this song, or I'm obsessing over my home, we're using this as like a noun, and I'm going to describe it as like a phenomenon that happens, right? And then compulsion is one form of response that we see, and I'll clarify that here in a little bit. But basically, an obsession is a thought, image, or urge, and that's something that the brain just sort of pops up. It's involuntary, right? So we all have automatic thoughts that the brain will cause us to have. We can't control them, and sometimes they're pleasant and sometimes they're not, right? So it's exactly what an obsession is, except that for someone with OCD, they get stuck, and it has a lot of that intrusion, we call them intrusions, has a lot of weight and importance, and they get stuck on it, whereas someone without OCD can just kind of let it go. So, but technically you can have an obsession or a compulsion or both. I've never seen a case where someone has just one or the other, because they really do play off of each other. And you'll hear there's really this old misnomer out there about pure OCD, and people will come in and say, well, I'm pure O because I'm not doing any compulsions. And once I do a thorough assessment, I usually can tell that, okay, they are doing compulsions, they're just doing mental ones that people can't see. And so once I do some digging, I always find them. So, but you'll still hear that phrase out there, and I think the only reason why they say still that you can have one or the other is I think there's probably a little bit of disagreement in what experts believe, because it used to be that people believed there was pure O. So a compulsion is some kind of behavior or mental act that the person does to neutralize that first obsession that pops into the mind. So we're trying to bring the anxiety down as fast as we can, and because we find something that works, then it's like I better do that again every time. But it only works in the short term, because the intrusions will keep popping up, and so hence the cycle that goes kind of around and around, right? Okay, so I won't stay on this for very long because we mostly have people from the community, but one of the things that really bothers me about the diagnostic criteria is that avoidance is not one of the symptoms. I see avoidance almost as much as I see compulsions. And in other anxiety disorders, we acknowledge avoidance as a symptom. It's a part of, actually that's a telltale sign that someone has an anxiety disorder. So it's a part of PTSD, it's a part of social anxiety disorder, specific phobias. So I always really hammer home this point because it doesn't get enough credit. And if we knew that, maybe like the assessment would be better in clinical settings than it is.
Can you give an example?
Sure. So a perinatal example would be like, I'm so afraid I'm going to hurt my baby, so I'm going to try my best not to be alone with the baby. I'm going to have a family member over as much as possible. I'm going to want my partner to be with me as much as possible. That would be the large form of avoidance. I think it can get, if the person's OCD is extreme, it can look like I can't be in the home, I better get away so I don't hurt the baby. That would be the biggest form of avoidance. And then sometimes we see little like small avoidances, like I don't want to think about my baby right now because I'm having these horrible thoughts. Okay, so I want to go through the themes of OCD because those are the ones that are possible for the perinatal OCD as well. But I always say anything under the sun is fair game for OCD. But these are the most common. So the first one is aggression or harm obsession. So this could be a fear of harming someone else or a fear of harming oneself. It can be on accident or on purpose, the feared thought. It can be direct harm, it can be indirect harm. So this takes a lot of different shapes. So if someone is having thoughts and images of killing themselves, but they don't want to do it, just again, that intrusion popping up in their mind, then sometimes they'll say, okay, I need to get all the medications and the gun out of the house. I don't want any belts, so I'm going to lock them in this closet. Like anything that they think that they could hurt themselves with, they want out of the way. And they may be, checking in with themselves to really test and see, like, do I want to kill myself or am I just having these thoughts? So when it comes to other people, it can be all kinds of harm. Like, I'm just cutting up vegetables, to prepare dinner with my partner, and I can't stop having thoughts about stabbing him or her with a knife. I'm just trying to lay my baby down for a nap, and I can't stop picturing smothering the baby with this blanket, things like that. But there's also accidental ones too, like, what if we get in a car accident, or what if I accidentally drop the baby and I'm picturing the aftermath of that, things like that. Death or existential concerns, so we call this existential OCD. So some people have thoughts, intrusive thoughts about what is the purpose of life, what am I doing here, why are my children here, are we being watched, are we being controlled? Some people use the example of like the Truman Show. What happens after death, and lots of fears about what it means in the afterlife. Not necessarily always religious either. Like sometimes it's like, are we just going to exist? And that makes me panic. Am I going to be suffocating forever and feel that feeling forever? And then of course just a fear of actual death, like death happening to me, death happening to my parents, just a general kind of fear of that. Contamination, this is the one that the public usually is aware of. So this is just a fear of being contaminated by germs, bodily fluids. It can be things in the air like toxic waste that we don't see, asbestos. For some people, it's also a fear of contaminating others. And I think that's the point that I want to make on this one, is that it's not always about being contaminated. It's also sometimes about contaminating other people and getting them sick and something happening to them. And for some people, it's not so much illness-based, it's just disgust with the feeling. It just doesn't feel good, and they feel like they can't tolerate it. Okay, so sexual themes. This is kind of a range of thoughts and images that people will get. So this might be just thoughts that someone feels for themselves is perverse to think about, to thoughts of questioning one's own sexuality. So this is not the normal, questioning or pondering or exploration that individuals go through or can go through. This is, again, I'm having thoughts like firing, and it feels inconsistent with how I really feel about myself, but I can't stop the thoughts. So I do a good assessment to just differentiate the two, and sometimes both could be going on. The other thing is harming someone sexually. So this could be a partner, this could be the child, your own child, this could be women or children out in the public, animals, anything that would feel, out of character for oneself, they might be picturing it. Sometimes themes will intertwine, and so I'm going to talk about religious scrupulosity in a little bit, but sometimes people will picture they'll sort of merge sex and religion together, and they'll picture, deities that they worship or something like that, like having sex with them or just sexual images that feel very inappropriate to them. Scrupulosity, so this is where I see this go two ways. So one is religious and one is moral. So individuals that really care about their religion or their values, they will sometimes get caught up in like the little rules and traditions and technicalities, and they sort of take them in a way that's too rigid, and they apply them to their life in a way that it starts to hinder their life. Other times it's like I said, they'll just think of something that feels sinful, blasphemous, sacrilegious, and they really are troubled by it. They feel like they're sinning or that they're going to go to hell or wherever it is that they believe. Other individuals have a moral scrupulosity, and this is just about being a good person, not hurting anyone's feelings, making the right decisions is really big. You see a lot of over-apologizing with this and sort of second-guessing what they just said, and if it was the wrong thing, they're making the wrong decisions in life. Relationship OCD, so this has to do with questioning maybe how much you like your partner, whether you love your partner, whether you miss your partner, whether you're attracted to your partner, but it can also shift and be whether your partner feels those things towards you. It makes you doubt sort of the stability of your relationship. But we've also seen this in parent to child. So oftentimes the person will say, okay, I'm looking at this photo on my desk at work of my kids, and I'm like, okay, do I love them? And OCD will make them doubt whether they do. It's called the doubting disorder. So they'll say, okay, I can't feel that love feeling right now in this moment. Why can't I evoke it? What does this mean? Maybe I'm a bad parent. Maybe I'm a bad person. Maybe I don't love my children. Or like maybe they're playing with their child and they're kind of testing to get that love feeling again. And when you can't get it right in that moment, they'll keep trying, but when they can't get it right in that moment, they think that means something bad. Bodily or somatic concerns. So really these two are their own conditions. One of them is an illness anxiety, just a fear that you have a health condition that you don't. You've already been to the doctor. There's already been tests to show that you don't, but you kind of don't believe it, and you interpret or misinterpret symptoms in your own body to be problematic that are not. And then the other would be like a body dysmorphic focus, where there's some aspect of your appearance that really consumes your day. And again, that's now its own condition. Incompleteness, symmetry, or exactness. So I think the general public has an idea about some of this, just making sure things are in a certain order, that they're symmetrical. But there's this phenomenon that we talk about in the OCD world called the just right feeling. And the just right feeling can play out in all kinds of ways. It can be what I say, how I say it, how I read a paragraph in a book, how I walk, where my soda is sitting, and no one else can feel what you feel for this just right feeling. Only the person knows. So when things feel out of place, they'll have to repeat or move and arrange things around. And then just kind of some miscellaneous obsessions. Need to know or remember information, fear of saying certain things are not the right thing. There's a lot of superstition that can creep up in OCD with numbers or colors. When you think about luck, or you hear like the number 13 or odd numbers are bad, or I can't wear that color or I'm going to hurt someone. And so these like superstitious things kind of get attached. There's also a phenomenon that we talk about, oftentimes paired with just right feeling, that's called magical thinking, where, if I don't have my computer in its place, or if I don't arrange all the things in my room, then I'm going to get in a car accident when I go to work tomorrow, which is a complete leap, right? That's magical. Those things aren't even connected. But for whatever reason, that's what OCD has brought up, and that's what they believe. Any comments or questions on this slide? No?
Is there a certain diagnostic tool that you use for a full assessment?
I do. I use the Yale-Brown Obsessive Compulsive Scale, YBOX.
Thank you.
So compulsion themes, the first is cleaning and washing, which obviously fits with contamination. But like I mentioned before, sometimes themes can intertwine. So someone might have an immoral thought, something they think is immoral, and then they have to go shower and like wash it off, so to speak. Checking takes a lot of forms. This can be checking the locks so there's not a burglary, checking that appliances are turned off or unplugged so there's not a fire, but also checking the body for symptoms of an illness, checking your work to make sure there's not a mistake, checking on your baby to make sure they didn't die. A lot of different forms with that. Repeating, so this would be having to reread, rewrite, or repeat any kind of action, just for whatever rule that OCD makes up. Maybe it's because you're really scared, maybe it's because it has to be right, but it's repetitive and there's really no function to it. Counting, this is exactly what it sounds like, so just, maybe you count the tiles in the ceiling, just random things that aren't very important when you walk into a room. Ordering and arranging, we talked about that. And the biggest message on this slide is the mental compulsion. So this is the part that a lot of the public does not understand. So I always find in every patient, they are engaging in rumination at some point, which is the biggest mental compulsion that I see go on, regardless of fear, regardless of OCD theme. So that's the time where they spend analyzing and thinking over and over, trying to problem solve, trying to prepare for the future. That's the voluntary part of the thought process. It may not feel that way, but it is. This can take other forms like reassuring oneself. If I had thoughts of hurting my baby, I might say, I would never hurt my baby. I love my baby. I've never hurt children before. When I look at my baby, I feel love, so I know I wouldn't do that. I don't want to go to jail, things like that. Just trying to find that certainty because there's some doubt in there being caused by those intrusions. Sometimes prayer turns into a compulsion, so I have to say this prayer at this time. I have to say it a certain way, or I have to say it so many times. Usually you can tell that it's become a compulsion because of when it happens and how it happens. So if it's happening at the height of their anxiety, they're trying to bring it down as fast as they can, or they feel like you must pray or else, then you can tell it's turned to a compulsion. Replaying events and replaying conversations. So people will doubt what just happened. So when I just laid the baby down, did my hand go over their mouth, or let me retrace my steps and think about what I did when I was getting them out of the bath. Did I touch them somewhere I shouldn't? So replaying the events, and sometimes it's conversations if it's between adults. So miscellaneous compulsions: need to tell, ask, or confess. So for some people, confessing to someone they trust becomes a compulsion. So if I run to my partner and I say, I had all of these bad thoughts today, and this is what they were, I have to tell you all of them. And then they might come back with seeking reassurance and say, okay, so now that I told you all that, do you still want to be with me? Do you still love me? Do you think I'm a good person? Do you think I'm a good mom? Do you think I love our child? Things like that. So some people will do both. Some people will just seek reassurance, but they won't confess the thoughts. So everybody's kind of different. So then there's quirky little compulsions of making lists, touching or tapping surfaces. There might be rules around the way that you eat, or the things that you eat with, or how you eat, that kind of a thing. Any questions on this slide? Yeah.
I had someone share with me that they had found money and they felt like finding change on the ground meant that their loved one that passed away was communicating with them, whatever. Could that be, because I see other things in this list, could that be related?
I think only if there was a larger pattern in their life of maybe other, like you said, other things on the list, it could be a part of it. But if that was the only superstition they had, I would say it's probably okay. Okay, so I'm going to try this first video to give you guys an example.
My name's Jerry and I have OCD.
Can you guys see it okay?
With giving out anything that I'm not getting back, words go through my head, and every word seems to be something bad. So this has to do with everything you touch all day long. It's that feeling that I'm never going to be able to go back and do this again, and that didn't feel right, so I better go back and redo it again.
That's a
Or
just right
something
here.
bad is going to happen. My biggest fear is harming somebody, and so you do stupid stuff. Reading this, all these words can all signify and sound bad, no matter what it is. And statement, make a statement at the police office, release her, getting released from jail.
Jerry has a particular kind of obsession that we call thought-action fusion. The idea is that a thought is just as bad as an action. If I think about killing you, it's just as bad as if I actually had killed you. And he is further concerned that he can pass these bad thoughts on to other people by handing them things.
Oh, you know what? I think I forgot.
He's
I'm
stalling.
making it look like that I'm actually reading something when things are going on in my head. I make it look like I'm reading, or I play it off like I'm doing something. You play it off as much as you can. A lot of times it works. Sometimes it doesn't.
Do a lot of work out here on cars and stuff like that.
I worked at a gas station years ago, and the person paid me, and I went to our little register, and I moved the money and touched it so many different times that the customer complained to my boss. I've probably lost 10 jobs because of the OCD. It cost me having friendships, relationships, it cost me money. I've pretty much been to hell and back.
Okay, so this character, well, actually, he's a real life person. Jerry, he has a fear that he's going to kill other people. So what was happening is, I think it was maybe the contract, I don't know for the show, but some kind of paper. And OCD will look for any little cue that you could be threatened by based on what your fear is. So they highlighted the word statement. For him, that made him think of like giving a statement to the police. I think there was something else about jail. So it starts to generalize to anything that it's related to. So a lot of people that have fears of harming someone physically or sexually, things you could get in trouble for. Anytime they don't like hearing about like sexual predators and murderers, and it'll generalize to words similar to that. They have to go get their fingerprints done for a new job. They're panicking that somehow they're going to be exposed even though they've done nothing wrong. And they won't do anything wrong. But it just terrifies them that somehow this is going to happen or people are going to find out about these thoughts. Because again, it's like almost as if having this thought is the same as doing this, which is not true. Okay, so as far as assessing for OCD, and maybe in your guys' case, just having a good understanding of what this is and maybe sharing this with people in your life so they have an awareness as well. Usually the onset is gradual. The only time we see a really sudden onset is in the perinatal time frame, or if, you guys might have heard of like PANDAS or PANS, where a child might get strep or some kind of autoimmune condition. It's as if they go to bed and they wake up and boom, those symptoms are there. So usually it is more gradual. In children, it's more common in boys than girls, but once we get to adulthood, it tends to level out. So it gives the age range of 6 to 15. You'll see different ages depending upon what literature you read, but 6 to 15 is kind of a vulnerable time for onset. And then also young adulthood, 20 to 29. I would even say like just that those late teens, early adulthood, kind of that college age. A lot of times you'll see an onset, or if they had symptoms from childhood, that's when it really blows up, especially if it's not been treated. So if someone has OCD before they become pregnant, then we'll see a spike around that perinatal time. But again, some individuals have never had any OCD and get it for the first time right around the perinatal period. So it's said that 1 in 40 adults have OCD, but we know that's probably a low estimate because it is so misunderstood and under-recognized, under-reported, misdiagnosed. It's a really big problem in the field. Oftentimes, people with OCD will have depression as well because it makes them so miserable. And in fact, I would say almost all of my patients have some level of depression. And as I treat the OCD, we track the depression. I'm not even treating the depression, but we track it. And the depression starts to get better as the OCD gets better. Now, if there's something else in their life that is contributing to the depression and it's its own sort of full disorder, and obviously those circumstances aren't changing, then of course some depression can stick around. It's very common for individuals with OCD to have other anxiety disorders as well, social anxiety, generalized anxiety, phobias, things of that nature. So when it comes to what causes OCD, psychology tends to not take a stance on nature or nurture usually, and oftentimes we'll just present both and say, hey, it could be multifactorial. These are all the things that we consider. So with OCD, the possibilities are that serotonin plays a role. I'm the neurotransmitter in the brain, and really the only way we know that is because SSRIs work to treat OCD. So we're sort of inferring we're like making a hypothesis based on the fact that they've been effective in treating OCD. And then there are also neuroanatomical differences as well. So this might be activity in the brain is different, or the structure or size of something in the brain is different. Learning theories, so it's believed, some people think that OCD could fit under like a classical conditioning, if you've ever studied that in school. So when two things are paired together, it's sort of a learned phenomenon, if you will, association. Or operant conditioning, where there's some kind of reinforcement for doing these behaviors. And then they've also seen in testing some differences in psychological testing, some differences in performance, likely because of the intrusions distracting the person from performing like they normally would, like on a time test or something like that. So we don't really say it's one thing or the other. I always describe it as kind of a perfect storm. Also, genetics could be at play, but we know not everybody that has OCD had a parent with OCD or a family member, and we also know that not every parent that has OCD has a child with OCD. So cognitive behavioral, from that point of view, which is primarily the kind of therapy that I do, we know that the conceptualization for OCD is that everybody has intrusive thoughts, but just individuals with OCD can't let them go. They feel responsible. Someone with OCD, these intrusions become stressful, they take up time, and they're usually about what the person cares about most. So this could be health, relationships, your child, your partner, religion, just being a good person, all these things that the person really cares about, OCD will kind of go after. The other thing that I'll say is it's also about oftentimes the most vulnerable of topics. So I would say like women, children, like the more seemingly vulnerable or maybe innocent. So children, animals, women, oppressed populations, individuals who are smaller, individuals who have a handicap. The rituals are successful initially, but again, that's only short term, and so they have to keep performing these over and over again because it doesn't last, but the intrusions keep coming. So the problem with doing those compulsions or doing avoidance is that it doesn't allow them the opportunity to habituate, to see that they can handle the distress that comes up, or that their fear doesn't come true. So I don't really promise anyone that their fear is not going to come true, because in some instances it could come true. Like a car accident could happen. Someone could even kill their baby, right? But we're trying to teach them to sort of live with the uncertainty that life brings and not give those intrusions so much importance. So I always use the example, if I was afraid of being in an elevator and I always took the stairs, I'm never getting the opportunity to learn that I can handle the distress that's going to happen when I'm in the elevator. And also that if you put me in the elevator 100 times, by the 100th time, I'm not going to be feeling distress. I'm going to have had the opportunity to habituate to it. But if I always take the stairs, then I'm never learning that. So this just gives you kind of a visual of what I've been talking about. So again, to kind of recap everything, the obsession is the thought, image, or urge. And I want to be really clear that, well, I think we use the word impulse and urge interchangeably. Someone was just saying the other day that their therapist told them urges are not part of OCD, and it absolutely is. So that's when it feels like it's going to happen. You'll often hear like it feels real. I feel like almost like I want to do it. I feel like my hands are going to move in that direction of doing something bad to the baby. But again, the person almost never or never acts on it. The probability is so low. I've never had anybody act on any of their thoughts. So those are the ones that are harder for people to really take in. I mean, images are pretty bad, but feeling like you're actually going to do something, like it's about to happen, is really scary. And the proportion of thoughts versus images versus impulse that occurs for each person is different. Some people don't have any impulse feelings, and they only report thoughts and images. One thing that I like to kind of throw in there just anecdotally is that some people will have sensations, like bodily sensations, and some people will have what they just call a feeling. And that comes first, and then their brain will make an interpretation about that, and the whole kind of ball goes rolling. Because both of those things are also involuntary, just like the thoughts, images, and urges. So the two kinds of responses, compulsion and avoidance, and then we break those down further, mental and physical. Between sort of point A and point B, according to cognitive behavioral therapy, the individual has some kind of thinking error. We call them cognitive errors. So there are a bunch that we all do, whether we realize it or not. And one really common one is misappraisals in OCD. And this is where the person is just misappraising the situation, misappraising that they're not going to be able to handle the discomfort, misappraising how much danger there is in the situation. For the compulsions, we went over what mental compulsions are, the rumination, the self-reassurance, replaying, sometimes the prayer. Behavioral compulsions are the things that people can see. So washing, checking, ordering, arranging, that kind of a thing. Also, I'll say a big one is Googling online. That's a big compulsion that a lot of people do. For avoidance, mental avoidance is really just thought suppression, pushing that thought away because it's ugly, trying to get it out of the mind. And sometimes you'll even see people shake their heads to try and shake it out, or close their eyes and try and push it out. Behavioral avoidance is similar to what I mentioned before, like maybe avoiding being alone with the baby. For some people, it might be little subtle avoidances, like, okay, I'll be home alone with the baby, but I'm going to hold the baby in a certain way so that I know I didn't do anything wrong later. Of course, they're going to doubt what they did and start doing avoidances and compulsions later. But so the top line, the obsession, that is really only directly treated with psychiatry and with certain medications. Most of them are a handful of SSRIs, and that's the only thing that can slow down these intrusions from happening and make some of them stop. But if you don't do any therapy and you just take the medication, you're not going to get any skills on how to manage this. It's kind of like a Band-Aid. You take it away, they're going to keep doing the same thing that they did before. However, it can be very helpful to have someone on medication while you're trying to do treatment, and also so that they can function. I would say at the outpatient level, about half of my patients are on meds, the other half are not. But if I feel that someone is suffering so badly they can't even concentrate in treatment or in their day, then I'm going to have the discussion with them that I think they should probably get on medication, because they could be feeling at least a little bit better than they do now. And then so for the misappraisals, that would be the cognitive piece of my work. However, with this one disorder in particular, when you go over the thoughts that are erroneous, and then normally you would have them sort of try to fix them and restructure them. But with this condition, when you do that, it turns into a form of reassurance for them. So if I were to say, oh, write down your thoughts, and they come in and they're like, I had thoughts about sexually abusing my baby, and then I say, well, let's restructure that to be more realistic, more balanced, more helpful. Where can you find the error in that? Then if they say, okay, well, I would never hurt my baby because I know that's the truth, then we've just stumbled into reassurance, which is a symptom of OCD, which is very unhelpful. So what do I do with this? I see they're doing errors, but I'm not in the business of like giving them reassurance. In fact, after the first few sessions, I pull it all back and I won't give any, no matter how much they ask. So I have been treating this for years, and the way that I was trained was actually sort of more along the lines of like the third wave approach to what we think about our thoughts. So it's more in line with an acceptance and commitment therapy style of just allowing the thought to be and not push it away. So what I do is I'll educate them on the misappraisals, and I'll say, this is what they are. I want you to be aware of them, because I think in some moments some restructuring might kind of be helpful. Education is one of your biggest tools and weapons to fight back that you have, but I want it to be sort of in the back burner, like a broad thing that you keep in mind, not one that you use in the moment when you're anxious. So I'll talk about them in the education phase, but I don't usually bring them up later. If I do, it's because we're speaking calmly, their OCD isn't escalated. So I don't spend any time doing cognitive restructuring, really. I'll go into, I do assessment, education, I'll bring in the family, because it always impacts the family, and the family has to learn how to respond differently as well. Then we go into skill building, where I pull from a couple of other therapies. So exposure and response prevention is the therapy that I do. It's the gold standard for OCD. But for many years, we didn't have, there were things that we were doing that were a part of our ERP, but we didn't give them names. So when ACT came along, and DBT, there were a few things from that, DBT being dialectical behavior therapy. There's a few things that I'll pull from those that we were already doing in ERP, but we didn't have a name for it. Because patients feel better when they feel like they have a skill, it has a name, this is what I'm supposed to be doing. So not everything in those other therapies will work for OCD, but there are a few things that do. So I'll do a little bit of skill building with that, teaching them about ERP, and then we'll move into the behavioral phase where we just stick with exposure and response prevention. So what does that mean? That means I'm exposing them to their feared situations, the ones that are causing them to compulse, the ones that are causing them to avoid, and I'm asking them to refrain from doing what feels intuitive. I'm asking them to do the opposite of what their brain is telling them, which, can sound very, kind of crazy to them, but that's where you have to, the education is really important in order to sell the point of the treatment, and it's very effective, so. Okay, so on the left side, there are the many misappraisals that we see. So a heightened sense of responsibility. So I have this thought, now I must do something about it. Overestimated perceived threat of danger or bad consequences. So they're misjudging the amount of threat in their environment. So just being with the baby feels like danger. And that can be really hard on a parent who is staying home with their child, and they're with the child, pretty much 24/7. It feels like torture. It's like a nightmare, but you're awake and you have to function and take care of this baby, right? Intrusions are given too much significance, so instead of just saying, okay, that's not an important thought, oh well, who cares, that was silly, they give it a lot of weight and a lot of value, and again, must respond to it. The belief that thoughts should and can be controlled. So a lot of people that have the ugly thoughts say, okay, well, I don't want to have that, so I'm going to try to push it away. I'm going to try to do something about it. My thoughts should be pleasant. Sometimes perfectionism is required, and that will also mean perfectionism in thoughts. People will want to think perfect thoughts too. Not being able to tolerate ambiguity. So when I say, you know what, it's the truth that we're all capable of hurting someone else, but we make a choice not to every day. That sends a panic into them, because they want to be black and white, I need to fit in this box over here. What do you mean that we're all capable of doing that? They don't want to think about it in terms of any kind of possibility. Thought action fusion, that's what the gentleman on the video mentioned. It's if I have a thought, it's more likely to come true. If I have a thought, that equals action. That equals that I'm going to do it, that the probability is high that it's going to come true, which we know is not the case. So what maintains this condition? What keeps it alive, other than the misappraisals? Selective attention. So when the person with OCD walks into a room, they're going to look for cues that support the hypothesis that OCD is presenting. So any little tiny nuance, any little tiny loophole, OCD will find it. So for example, if somebody was afraid that if they identified as straight and they had intrusions about being gay, then they might panic when they're sitting next to their best friend and their best friend, looks really attractive, or they're really enjoying their time with their friend and they're very hyper aware of it, and now they're panicking that means that they're gay. Physiological factors, fight or flight. So these intrusions that are being set off in the brain are kind of like false alarm, fight or flight. So we're conditioned to respond to alarms that are going off, right? The way that I always conceptualize it is fighting is the compulsions and flight is the avoidance. And we have to disrupt those responses in order to retrain the brain that we don't respond to these alarms anymore. Safety-seeking behaviors. So that's a phrase we use with a lot of anxiety disorders, but in the case of OCD, this is compulsions and avoidance. And avoidance doesn't allow people to have that corrective experience that they're basically going to be okay, and if they're not, they'll manage through it. Concealment of obsessions, because there are so many individuals that have sort of the ugly thoughts that are on repeat, they're afraid of how other people are going to feel about them. They're scared to open up. There's lots of parents who are afraid they'll go to jail if they just tell their doctor that they're having thoughts of killing their child or sexually abusing their child. They're afraid Child Protective Services will get involved. Some people are afraid to even tell their partner or even a friend, and they'll just hold it in and suffer for years. I mean, I think the average start of therapy is about 14 to 17 years after someone's OCD first develops. I think the internet is probably making that better because people can kind of Google their symptoms and figure out it's OCD, but before that, lots of people would suffer for decades not knowing what it is, and even if they know what it is, they don't know where to go for it. Attempted thought control, so just trying to push those thoughts out. We know the harder we push something away, the more it comes roaring back. If we say we're not going to think about pink elephants for 30 seconds, you're definitely going to think about pink elephants for 30 seconds, right? Okay, so for the postpartum piece, 3 months postpartum is a vulnerable time for all psychiatric disorders, but I will say that for OCD, I'm really about the preventative measures and the education. So I think it's never too early to educate and assess, so I'll just put that out there. I wouldn't, I would never recommend that providers wait till that point. And sometimes individuals will start to have symptoms when they're pregnant. They haven't even had the child yet. So, okay, if you're thinking like, well, don't a lot of moms, aren't they kind of like, or parents like worried about, kind of checking on your baby and making sure they're okay? It's kind of like what Kara said about, you're responsible for keeping this baby safe. And that's exactly what happens. You're constantly scanning the environment for like threats of danger and how to keep them alive and how to keep them well. So how do we distinguish between just a mom's like anxiety rising and actual OCD? So we look at the overall pattern of behavior. We look at the time that it takes, that they spend in their day and the amount of distress. And usually either the individual or someone in their life can tell that it's excessive. So it's either excessive or it's irrational. Aggressive obsessions are more common for this subset. SIDS fears are also common. There's a lot of self-reassurance. Again, like I mentioned before, like I'm a good parent, I love my child, I would never hurt them. Distraction, so trying to distract themselves away from the thoughts. And avoidance. Back in the day, I used to always hear moms come in and say, I hate hearing about Andrea Yates and Susan Smith. Those were the two like legal cases that everyone couldn't stand, and they would avoid hearing about them, even though they would still come up. And now that enough time has passed, there are some parents that are like, I don't even know what that case is. But for many, many years, those were the two most scary cases. And they're two completely different situations, but all they know is the women killed their children and they don't want to be that. So the thing usually with OCD is the person will have a pretty good insight to their symptoms. So you can sort of try to drill logic into them all you want, but they're already aware oftentimes that their fears are excessive or irrational. Only a small percentage of individuals sort of become delusional and actually can't assess their thoughts as irrational. Yes?
Can their obsessions look like paranoia?
I
Like
think,
paranoid thoughts?
like what?
Can they look like paranoid thoughts? Because you were talking about earlier, like it could be relationships, it can be different.
Mhm.
Like, can it look like paranoid thoughts?
I think some of them can look a little paranoid, but I wouldn't say that it would, if there was like paranoia across the board, I would look at maybe another condition, but I think under the umbrella of what OCD has, some thoughts can seem paranoid. Yeah. So ego dystonic intrusive thoughts, so that's really a psychodynamic term, and I'm not a psychodynamic therapist, but it does explain it well. So the thoughts are ego dystonic, meaning they're not in line with the individual's values, and they wish they didn't have them, as opposed to ego syntonic, where yes, my thoughts are in line with my values, and it feels great. There's a big difference. So that's a key into telling whether this is OCD fear of harm versus something else that might be going on. There's also more likelihood for contamination obsessions. So sometimes it might just be that I'm afraid, my baby's going to get sick, either by something I do or by me not keeping them clean enough or whatever. So we also see a lot of that. I already mentioned that if they have OCD, then we see the spike in symptoms. And so there's a lot of different studies on the different hormones and the ways that they may contribute to OCD. I definitely think it can have an impact on the fluctuation of symptoms, but the thing is, this also happens in fathers, and I know sometimes I know there's some theories about things changing for new fathers as well. So the stance that the International OCD Foundation has taken is that it really has to do with the increase in responsibility that just comes with being a parent. So again, remember when I said it's usually about the things you care about most or that are most important to you at the time, about the most vulnerable and innocent things, then that's like prime, for OCD to kind of go after a parent, with a new baby. And I think that we really need to raise awareness about how this happens in fathers too. It looks exactly the same. So for treatment, they say assess within 2 to 4 weeks of delivery. Again, I'm somebody who's like, let's start talking about this way in advance. But definitely wanting to follow up because it might not develop, until a month has passed after the baby came. Asking about intrusive thoughts, not just harm, but also contamination and checking because it can take those forms as well. You'll want to pay attention to how often, how strong is your anxiety after these thoughts, how impairing is it. The white box screener is the one I mentioned earlier that I use to assess for OCD. It's kind of long, so that may not work in like a medical setting, but they can certainly add in just a few questions, like now when you go to the doctor and they ask you if you feel safe at home and things like that. They could really just throw in at OB offices. They really could throw in just a few screener questions just to kind of tap into this and make sure that the individual isn't experiencing the OCD, and if they are, to get them help. So you'll want to differentiate between other kinds of mood disorders that can come up in that perinatal phase. And I think one way that would be helpful would be like giving an example and normalizing this experience. So, you might say like, well, some parents experience thoughts of bad things happening to their children. Has that happened for you? And so hopefully, like, A, we already normalized it, and 2, here's my window of opportunity to speak about it. So don't wait for the patient to bring it up, but actually start screening and asking about it. And of course, just assessing for mental status, that just means how they're doing psychologically in that moment. And then medical tests. Is there anything, like Kara talked about the thyroid, is there anything else that needs to be checked and ruled out before we jump to any conclusion with diagnosis and such? So for treatment, the gold standard treatments are both medication and cognitive behavioral therapy. With the medication, it's very effective, but you don't see quite the numbers that you see with the therapy because the therapy is really beneficial long term. So the pros is that it is safe and easy. The SSRIs work well. You do have to be on a higher dose. There are certain thresholds for the SSRIs that do work on OCD. Otherwise, if you're below that threshold, you're not going to feel the full benefit. You may not feel any benefit. And oftentimes patients will tell me, well, I felt worse until I got to that right dose, and then I finally felt better, which is tough because that's several weeks, maybe even months, depending on how long it takes to titrate before they're feeling the best effect. And sometimes they want to quit the medication before they get there. A lot of people with OCD are scared to take medication, so just doing that is an exposure for themselves. So the cons are that we don't see the same symptom reduction that we do with therapy. There are potential side effects, and it's not really sustainable unless you keep taking the medication forever. So I list many of the common antidepressants. Most of them are SSRIs except for anafranil, that's an old tricyclic. And I often also get individuals that come in with a script for Xanax or Klonopin. Maybe they're taking it PRN, maybe they take it daily. And that's really not going to be beneficial for them in the long run. Those aren't really supposed to be long-term medications anyway. And I want them to learn to be able to tolerate anxiety and distress and be able to see that they can get through it without taking the medication. So my hope is always that they'll taper back or taper completely off of it. And I can work with their psychiatrists with that as well, but if they are taking it, I don't want them taking it before they come to session or before they do their homework, because we have to tap into that anxiety to get the work done. And you can't feel, too relaxed from your benzodiazepine medication. So cognitive behavioral therapy, we see a 60 to 70% improvement. It's a chronic condition. I never promise a cure. Pretty much since we all have intrusive thoughts, those are never going to go away. That's not the goal. It's really in how we respond to them. So the goal is to teach them how to manage and to worry about them less. And people make huge strides with this therapy. So there's a lot of long-term benefits to this. The con is that it's hard work. It's like scheduling anxiety in your day. It's a really tough therapy, and it's not easy to find specialists and people who are trained to treat OCD. Like I said, even within the mental health field, it's not assessed appropriately, much less treated. And there's so many little nuances to everyone's presentation of OCD that you have to be able to catch these little things, that might be happening. Like, I'll catch somebody like doing a mental compulsion. Maybe they didn't even notice that they were checked out and engaging in that, or maybe they're reading something that I asked them to read for exposure and they're rushing through it, and that's a form of avoidance. So just being able to catch all these little things, otherwise the person's going to stay sick. They're not going to get better. So it's really important. Okay, so with exposure and response prevention, which is the treatment that I do, you're trying to get the person to actually be in the situation that causes them anxiety, or to think about the situation that causes them anxiety. Obviously, there are some things that we would never purposefully invoke, or we're not going to have people be actually harmed. So we might do some kind of imaginal exposure where they're imagining one of their fears happening. Other times it'll be something that we call in vivo exposure, where it's live. So it might be that they spend time home alone with the baby. It might be that they're the ones that have to change the diapers because they've been avoiding it for so long, or giving a bath, or something like that. So I mentioned this, I think, before, that if they are a reassurance seeker, I don't engage in that. So I have to teach the family members not to engage in it anymore either. And every family member tends to do the same thing, where they just want their loved one to feel better, so they'll give them that reassurance. And sometimes they need to move on to like the next task in the day, so they'll just give them reassurance so they can move on. So I also have to train the family members to no longer give in. And it can be really hard because some people really pressure their family member for that, and they're really struggling. So in the treatment, we approach this gradually. We don't just flood them with the biggest fear that they have. I do a really thorough assessment of what kind of behaviors they're engaging in, and then we take that and we build different exposure scenarios and we kind of rank them in order of difficulty. And we work our way up the list. We may not do everything, but once the person gets stronger with each item, it just kind of builds on each other, and then it generalizes, and they are stronger in other areas, other situations that present themselves. I usually try to do some kind of measure, an objective measure of how their symptoms are getting better. So I might give them the Y box again halfway through, or at certain intervals, and then of course at the end, so I can see in an objective way, how far did we get their OCD to decrease? Did it go from extreme down to moderate, or severe down to mild? And that's a nice feeling for them to see the big change in their numbers. So there's a lot of homework with this therapy. It's not just exposure in session. One time is not going to be enough. So they basically go home and repeat what we did together if they can, if they have the means to, and they do that 5 to 7 days a week, depending on how much we schedule. And they're also supposed to be seizing opportunities throughout their day to really challenge themselves. I call it an ERP lifestyle, so that hopefully they know they need to keep doing that forever to keep OCD at bay. And then the other thing is just that once they do make a gain and they do accomplish something and they habituate to something and get used to it, we don't go back to where we were. So you're expected to work on maintaining that forever. So if you started giving the baby a bath again, now we want you to keep giving baths. You don't have to do it every time, but we want you to participate in that, until you don't have to give your kids baths anymore. So maintaining progress. And sometimes we'll push with exposure a little bit further than the average person might do. Like you'll hear sometimes, like, contamination is an easy example. If someone has a fear of germs, and we'll say, okay, well, today we're going to be eating food off the floor. And they're like, the average person doesn't do that. Why would you ask me to do that, Well, it's because if you see that you can tolerate this, then you can definitely tolerate, going to dinner without washing your hands and, sticking your hand in the chip bowl or whatever. So also because we see a little bit of regression sometimes after they discharge. So if we push them a little bit more than the average person, if they regress, they're okay. They're right here where the average person is. And we try to have a lot of fun with it. I incorporate humor wherever I can. I want them laughing at these thoughts as if they're silly and ridiculous. But at the same time, there's a lot of really disturbing and depressing and explicit thoughts that we talk about. And so you have to be really comfortable with being able to go over those things. You know, I'm not going to model any kind of fear for them because they're already doubting themselves. That's going to make them be even more fearful as well. Okay, so I just want to show you an example.
To undo it in some way, and they get trapped.
And I probably shouldn't tell you, but you know what, we're throwing it all out here, and here's where, I've never told any doctor about this or anything. I was at somebody's house, and
So this is him about to open up to his doctor about something that he's never told anyone before, and then I'm going to show you an example of exposure.
we're watching scary movies, and some guy was going around, like this. And he had put this plastic bag over this person, and you can see
I may just have to play it. I don't know why the screen's not showing it.
the
Sorry.
fear in the eyes and everything, they're shaking it. And I got a panic attack, and it was like, oh my God, what if I ever do that? That's just crazy.
Well, you gotta face it.
Well, you don't want to go around telling people that you have a fear of hurting people.
You think about it because you're afraid of the idea. The reason that it keeps coming up in your mind is precisely because it's the last thing in the world you would want to do. Sometimes.
So while they were talking, he compulsed. So and his doctor's speaking, and he's like, I pray to God. And so he was having, these thoughts about harming someone, and he had to do something about it. Okay, well, I might have to skip the last video then, because it's not showing, and you definitely want to see what happens. So basically, for the exposure, what his doctor decides to do, and they worked their way up to this, is that he had him hold a knife, and he was sitting next to, I think, his sister, and there were other people in the room because it was a group, and they were doing kind of a group exposure. So just holding a knife made Jerry, completely panic at first because he feels like he's a dangerous person and shouldn't be around knives. So what happens in the clip, though, is the doctor says something that gives him, I think it was the doctor, says something that gives him reassurance, and he throws the whole exposure. So all of a sudden, Jerry's like, oh, you could see him, feel better. And I was like, oh no, you're not supposed to do that. But they do a knife exposure again, and this time they up the ante. And Jerry has to hold the knife up to his doctor's neck to show that he can have a knife and he's not going to hurt anyone. And so, of course, that was very anxiety-provoking for Jerry. That's probably going to be 100, on that hierarchy list. So, but he makes it through, and his anxiety comes down fairly quick, I think, relative to what most people would experience. So the key is staying in that exposure until your anxiety comes down by at least 50%. That might take an hour. That might take 15 minutes. It just depends on how difficult the exposure is. And what we see is as they repeat them over time, the amount of time it takes for their anxiety to come down usually gets shorter and shorter and shorter because they're getting better. They're getting more used to it.
Would you do something like that?
I have. I do it all the time. Mm-hmm. And in fact, I'll turn around. I'll say, okay, I'm going to close my eyes now. Okay, I'm going to turn my back to you now. And I don't want you holding the hammer like this. I want you holding it like this, above my head. And they're like, what are you doing?
It gives me anxiety just thinking about it. You're a brave woman.
Okay, well, I'm towards the end anyway, so I'll just talk in this last slide. So basically, take-home messages are that shame prevents many people from getting treatment. So the more conversations we have about this, the more we open up about our silly, weird, ugly thoughts, the better it'll be. So usually when people come into treatment, I'll share ugly thoughts that I've had just to kind of normalize it, and it kind of breaks the ice for them to be able to share with me. Also, just keeping in mind that these fears have little probability of coming true. Again, I never say never, but that's the whole point of this condition is I have these thoughts that don't fit with, how I want to live my life. I can't help it. And so we know that they're the least likely people to act on them. There have been times where I've seen, an individual with OCD and they have some other kind of condition because usually people with OCD are very over-conscientious and careful and they want to be kind, and you can just tell that they're very sensitive and in a very endearing way. But sometimes they'll have, another condition that might shift their mood or their presentation in a completely different direction. It doesn't feel like there's someone with OCD in that moment, but it's because there's another issue going on that's causing, anger or dysregulation or something like that. So whenever you're trying to distinguish, okay, how do you know this is a person that has OCD, harm thoughts, versus some people that have acted and harmed their children? How do you distinguish the two? And as a clinician, obviously that's with a really thorough assessment. I mean, we have to, even if someone doesn't have OCD harm thoughts, we have to assess for risk of suicide, risk of homicide, or hurting someone anyways. So I think it's really all about the way that you question and the way that you're careful. And I don't even think, so if you were my patient and I were to say, okay, you're like, you have thoughts of hurting your child, I probably wouldn't come back and say, like, well, do you really want to? Because OCD is a doubting disorder. They're going to go, like, some people are going to tell you, no, I don't, and other people are going to start to panic, like, and they'll expect to have the feeling in the moment that they don't want to, and if they can't evoke that, then they think there's something wrong. So again, just giving an example of thoughts that people may have, then you can easily endorse back to me what it is. And what actually happens is a lot of people will say, well, I'm having these thoughts, and then they'll like rush to tell you, but I would never do it, but I don't like them. And that's not how someone who's homicidal or suicidal usually presents it. The people who are thinking about those things as a solution to a problem aren't going to rush back and tell you, but I'd never do it usually, right? Like, they're not going to start giving you reassurance, but people with OCD will. So that's one of the ways that I can tell. But also looking at the bigger clinical picture. Are they engaging in the misappraisals? Are they doing a bunch of avoidance? Are they doing compulsions? So that's the way you can kind of distinguish between the two. And then in a normal risk assessment of somebody who is suicidal or homicidal or may hurt themselves in some way, their history might be able to help you with that, just like a normal assessment where you're looking at risk factors and protective factors and legal history and patterns that have already been in their life. So that can kind of help distinguish between the two as well. And so then at that point, the biggest thing is just, again, getting them to somebody who knows how to treat the condition, because the other big problem we have in mental health is that a lot of people don't know how to treat it, and so people will stay stuck. They'll be in some form of talk therapy, and the therapist might take some kind of approach. Well, what does it really mean that you're having these thoughts about harming your children? What happened to you in the past to make you have these thoughts? And I usually don't even really focus on the past at all, unless the person had a significant event that relates to their OCD, and some do. Sometimes it's just a distinguished, memorable event. Sometimes it's an actual trauma. Not that the trauma necessarily caused the OCD, but the themes might relate. And a lot of people just feel like they got OCD out of the blue and there's no significant event. But again, I'll never spend that time spinning wheels on the back. We're just going to deal with this in the front. And it either reduces, or for some people the theme might go away. Because this disorder is chronic, one issue that we see though is it can wax and wane and it can be episodic. So you might have remission for a while or partial remission, and then you have another episode, and it might be a new theme, and then a few years later you might get a different theme. And so usually when people come to see me, they have at least two big themes going on right now, and they've had other themes throughout their life in the past. Rarely ever do I have someone who just has one theme. So just kind of preparing them for the long haul, that we're going to have to use these skills, always when intrusive thoughts come up. So any questions or comments? Yeah.
What's your assessment fee?
What's that?
What is your assessment fee?
Can I tell you later?
Sure.
Okay.
In case I refer someone.
Oh, yeah, I'll talk to you after. Yeah. Anyone else? Okay. I just wanted to mention, I know we all put our cards in the bags and such, but there are some pamphlets from the Postpartum Resource Center of Kansas in the back. They do have like a warm line. If anybody ever needs anything, you can call it, leave a message, and someone will return your call. It's just kind of a resource to try and connect you with whatever need you might have. So just want to put that out there. I don't think it matters if you're on the Missouri side. And my contact information is on the card, so you're welcome to reach out to me if you ever want to make a referral. So thank you, guys.
Thank you.